So thank you very much for this opportunity. I want to start off by just asking, please raise your hand if you know what happens when you dial 988. Okay, that's not enough people, really. So 988, since July 1st, 2024, is the US National Suicide Prevention Lifeline. And what happens if you dial that from a cell phone or landline in Vermont, you'll be connected to a crisis counselor who's specifically trained to work with people experiencing suicidality or other mental health crisis. And what's remarkable about that is, like, I think we're up to 98% of those calls being answered in state, which is probably a record in the United States because they used to be answered all over the country. And when when that person answers the phone, they know about Vermont resources, and they can actually, based on where you live, they can help you get connected services, or someone you're concerned about get connected services. I just mentioned that because, first of all, not enough people know about it. And second of all, it's like one of the many, many amazing things that's happened in Vermont in the past, I would say 15 years around suicide prevention. So 20-ish years ago, we had almost no focus on suicide prevention in the state, despite having one of the highest suicide death rates in the country. And we actually had years where we had the highest death rate in the whole Eastern US, was in Vermont. And when you look at the leadership and the engagement of people, like people with lived experience, people in the mental health professional, primary care providers, specialty providers, they've all come together and they've really made some amazing changes. I'll tell you about some of those changes. So that's me. This is why we started doing this work in earnest. In 2008, I was sitting at my desk in VCHIP and I got an email from a colleague in state government, and they were writing the state's first suicide prevention grant to the feds, to an agency called SAMHSA. And they needed a nerd, basically. They needed somebody to write the QI section and the stats plan and all that stuff. And they knew I had a PhD in psychology. So I was like, oh, yeah, I'll do it. I actually knew nothing about suicide, and I had done this PhD in psychology. I knew that suicide was an outcome. That's all I knew. I just didn't learn it. I did know from personal experience, I knew that 3 young men died at my high school while I was in high school of suicide, 2 of whom were my friends. So a little bit of a personal motivation there. This is the state's motivation. If you look at the blue line, that's the US national suicide death rate. It's people per 100,000. And that's from 2013 for 12 years to 2024. The red line is Vermont. So we are always higher than the state. And actually what this graph sort of conceals the fact that our trend was actually worse until 2019. And in 2021, our trend starts getting better relative to the US trend. But we had a serious public mental health crisis, and it was suicide, and it wasn't getting enough attention until people really stepped up and started doing things like writing grants. We'll go back to this actually. So we got the grant, which was fantastic. And we spent 3 years, we developed trainings, and we implemented youth suicide prevention trainings in pretty much every middle and high school in the state. And then we got another 3-year grant. We were able to even further expand those. We got additional funding, and that allowed us to expand these sort of training models to adults and to special populations, and a little bit in primary care, a little bit in emergency departments. So trying to bring suicide prevention, what we used to call gatekeeper trainings, and now we call suicide awareness and skills trainings. The idea is anybody can be involved in suicide prevention. And one of the things we taught was SAG. SAG is, if you're concerned about someone, show you care, ask the question. The question is awkward. And the question is, are you thinking of killing yourself? Are you thinking of harming yourself? That's a hard question to ask. And then the G is get the person to help. So SAG is just one example of what we taught. I'm already down to 2 minutes and 52 minutes, 52 seconds. How did that happen? Okay, so we are going to go ahead. But the problem is, we had all this amazing training. We trained thousands of people. I rode in a car with a physician, and we hit like 8 different Vermont cities, and we just did these trainings with EMTs and other first responders and clergy, right? But training, we have no evidence that training works except for shifting people's attitudes and knowledge. We know that. We know those trainings are effective. So here's an example of some of the other things that started happening about 8 to 10 years ago in Vermont. And training, obviously, Governor's Challenge is specifically focused on veterans and their families. Fantastic effort. Comprehensive Suicide Approach Grant is a CDC grant where I'm part of that. And we're focused on specific industries. So farming and construction, if you look at the stats, are disproportionately highly impacted by suicide in Vermont and nationally. So that's a very targeted approach, trying to get a little bit upstream. Emergency departments, all 14 Vermont emergency departments have now done at least one project with Vermont Program for Quality in Healthcare, where I consult with them specifically on suicide prevention in the ED. So fantastic. And Suicide Safer Pathways to Care is all about building connections between primary care practices and their local designated agency, which if you don't know what a DA is, it's basically our county mental health departments in Vermont are called designated agencies. It's the DA system is our public mental health system in the state. So I'm going to talk to you very briefly about zero suicide. Oh, I can't see the numbers anymore. Okay, I went to sleep. Okay. So zero suicide, actually don't want to show you that one quite yet. Zero suicide is a package of evidence-based changes that we adopted and we started implementing with this public mental health system back in 2016. And I can't even tell you all the different things. There's like 7 categories of activities. The idea is you build a pathway from initial identification of risk all the way to treatment, referral, follow-up, and post-discharge caring contact. Here's our data, because we have the training data, but we never had actual outcome data until now. Well, last January, February anyway. This is 12-year trends. That green line is the same line from the earlier chart. That's Vermont suicide death rate. Look at the orange bars. The orange bars are the height that they represent the percent of suicide decedents who were seen in the public mental health system in the year prior to dying. What this means is when we started, the blue arrow there, year 4, that's when we started zero suicide. And look where we got in year 11. Year 12 went up a little bit. I did the stats on this, and the second 6 years are significantly lower suicide death rates than the first 6 years. So something's going on. That reduction in the second 6 years translates to 90 people who didn't die because the system has actually been making changes, not just training. Training is not enough. You have to change the EHR. You have to change the type of therapies that are being offered. You have to start new things like suicide-specific screening. You have to do safety planning. There's a whole package of things that have to happen. And the sort of punchline to this is it works in the mental health care system. We've done it. We've seen this 54% reduction in deaths in the mental health care system. We don't really have it in the healthcare system. Imagine if we could get it in the healthcare system. Imagine the scale of the change we might see. Thank you.